Welcome to the American Hospital Association's webinar for trustees on developing creative affiliations for new capabilities. I am pleased to introduce our speaker, Anu Singh. Anu Singh is a managing director at Kaufman Hall, where he provides financial advisory services to healthcare organizations and companies nationwide. Mr. Singh leads the evaluation, structuring, negotiation, and execution of mergers, acquisitions, partnerships, joint ventures, and other forms of transactions. He also leads projects involving the assessment of strategic options, growth strategies, and business unit segment viability. His clients include national and large multi-regional health systems, academic medical centers, community hospitals, large physician groups, health insurers, and non-acute care providers. Mr. Singh has advised on or evaluated more than 100 healthcare transaction-related engagements. It is now my pleasure to turn the program over to Anu Singh.
Thank you very much, and thanks to the American Hospital Association for allowing us to present this presentation on developing creative affiliations for new capabilities, particularly in the face of healthcare reform and transformation. We're seeing a significant amount of change in the industry. I'm very thankful to be able to share this content and this topic today. Where we'd like to start is talking about the context of industry transformation. And where that begins is the new reality that we have in the healthcare field today. Our view and our point of view is that the transformation within the industry has a number of factors driving it. It has a number of outcomes that are also driving it. Employers and insurers are continuing to think about new products and new solutions for transformation. The healthcare consumer is becoming a much more active participant in how healthcare is delivered. Combined, that's resulting in a shift to value-based care models and new ways of defining how care should be treated, care should be delivered in communities today. And of course, redefining access and delivery for that care. We're seeing less sites of care and more mobile and technological advancements in how care is delivered. And we're also seeing disruptive competition. We're seeing organizations that are not looking to compete directly with hospitals and health systems across the board, but picking and choosing certain areas of their operations, certain areas of their care and services that they would like to compete against and entering that phase of competition. So the reality is, regardless of what happens with reform today, whether it remains in place, whether it's partially replaced, or whether it's entirely replaced, we feel that there's a number of business drivers in these black bars listed on this slide that transcend what's happening from a political standpoint, and that really point in the direction of how this industry will change. And so we believe we're at a policy agnostic stage here, and that's an important undercurrent to the discussion because it means that a lot of these other drivers are primarily driven by the business and legal fundamentals in the industry as opposed to the political climate that we're in. What that means to providers is you can't just focus on the forces of competition. If we go back to the Michael Porter model and think about general business strategy, it's no longer just a competition within the industry participants themselves. There are replacement technologies that are coming into play. There are new entrants that, as I mentioned before, are picking at specific elements of what hospitals and health systems are doing. But there's also a greater intensity and focus on how you compete for a new healthcare consumer. Before it was patient-driven, and now it's going to be driven a little bit more on patient lives. And we have a slide that I'll touch on this in 1 second. But the takeaway for this point is that it's not just about the forces of competition within an industry, it's also the overall basis of competition, who participates in that form of competition, and what directives that the end customer will have in making the decision of who to choose to provide that care in a new competitive landscape. This slide summarizes the old business model and the new healthcare business model. And this touches on a component of the last slide very clearly. Off to the left, for a very long time, the industry was organized in a way where patients saw doctors, doctors went to hospitals, and performed the services that the patient needed. And so it was one single healthcare transaction in a pretty linear format. Off to the right is the new healthcare business model. And this is very different because at the very top where you see customers, that's actually not the patient anymore. That's the aggregator of lives. If the government is the payer and Medicare and Medicaid are the customers, they're looking to figure out which health company can manage the population that they serve, not just when they're sick, but also when they're healthy, not just for an acute episode, but perhaps for a non-acute episode of care as well. In some cases, this is even proliferated into providing for a whole bundle of care or a whole episode of care for a particular patient. So that customer to the top is the government payers. It's large and mid-sized employers that are looking to come up with their own plans or their own plan design. And what they're looking for is to select a health company in the middle. Now, I'm often asked, how is this current wave of consolidation different than what we saw in the 90s? And one key differentiator was that health company in the middle, when we saw the last phase of aggregation in the industry, was almost always the payer. It was the insurer. And in the new healthcare business model, health systems have invested and found a way to access some of the data that was so relevant and important in the last wave that we had in the 90s. And so what that means is health companies can be a payer or insurer, but they can also be health systems. They can be health systems that have determined that they want to own and operate everything below, the hospitals, the physicians, the outpatient care centers, and many other services which the slide just doesn't have the space to capture, but also that those health systems can own parts of these components of this content of care on the bottom and maybe contract, negotiate, collaborate, or otherwise partner with other organizations to fulfill that business model. So it's a much more complex, much more holistic model, and one that lends itself into thinking much more about industry transformation and the components that go into it. On this slide, we have sort of the scaffolding, the infrastructure that goes into place to become that healthcare company. And 10 years ago, the margin on the far left would have been an important element. Cost management and margin, to find a way to do more with less. That was more of a strategic initiative almost 10 years ago. Because of the nature of change and transformation in our industry, however, and because of other fiscal and economic pressures, we are in a place where, by and large, healthcare systems are getting paid less on a real basis year over year. That means their revenue is essentially flat, and what's happening is their expenses are continuing to grow. So today, when you look at the column on the left, that's no longer a strategic initiative that health systems should be considering. It's actually a strategic and imperative. It's something that they must do just to keep path with the trajectory of where revenue increases are going. In the middle are the business reconfiguration concepts. These are elements that market by market, health systems and hospitals are starting to get more and more involved as part of their strategic plans. They're developing the new contracting models to embrace some point of value reimbursement somewhere in their payer mix. They're more actively engaging with the consumer to figure out how they can please the consumer in coming through a hospital or a health system, or at least find a way that they can access the health system in an easier, more efficient way. Off to the right are a number of elements that I think will grow and emerge over time. Today, there are health systems that are working on some of these, but I think by and large, once the business is reconfigured in the middle, only then can you become a more effective manager of care. And these are areas that I think most health systems will look for in the future as to areas where they should be focused. And actually, these are the elements that will allow them to thrive and seek to get not only quality, but also financial and economic benefits of that migration from a fee-for-service world to a value-based world. So all of this has implications to what's happening in the partnership realm as well. And a good place to start in thinking about this are some of the facts and statistics that are fairly well known, and maybe a few more that I think we'll bring to light that help illustrate why this is a very different trend from ones we've seen in the past. Let's start with the basics though. Here on this slide off to the left, we have the number of hospitals in the United States that are a part of health systems. And we have 2 points in time that we measured this, 2000 and 2015. And note the change, that roughly half of the hospitals were part of health systems in 2000. In 2015, that number is much closer to 2/3 of hospitals that are now in health systems. And again, I think that underscores the amount of community hospitals now that are looking to uplink with larger organizations and health systems to be part of their systems. But there is a piece of data that's missing here, and that is health systems combining themselves. When 2 health systems combine, and say one organization brings 6 hospitals with it and another one 8, you have 14 hospitals that are now a part of a much larger organization. That's not actually being captured in this graphic here, because it only shows community hospitals entering into health systems. So we thought we would take a look at what's happening at the system-to-system level, just to see how widespread and how unique the trend is of larger, more established organizations transacting as well. And the slide on the right starts to tell that story. What you have here are health systems whose net patient revenue base was $1 billion or higher, so billion plus revenue generating organizations that were either the target or the smaller organization in a merger. So meaning they were the smaller entity in the merger, so there's a large organization they merged with. And these are the number of those types of transactions that have taken place over the years. And 2012 set a standard at 6, and you can see it's been pretty consistent since. 2016 was a little bit lower at 3. However, 2017, we've had 4 just in the first quarter. And so what that gives you is a picture of a very consistent level of billion-dollar-plus revenue-generating institutions transacting. But here's the interesting part. If you were to take the scale off to the left and start in 2010 and go back to the history of record keeping, you would only find 2 organizations in that entire period of time that met this criteria. So this is, in a word, unprecedented. Until 2010 and through 2010, there were only 2 organizations of $1 billion plus that transacted as the target or the smaller entity. And just 2 years later, we have 6 just in 1 year, and now we're keeping pace with that. So that really is a significant change in how the transaction activity has taken place, and namely the participants thereon, particularly looking at much larger organizations. This trend continues when we slice it a slightly different way. Our approach here was to say, well, regardless of size, let's look at the strongest organizations in markets today. And as a proxy for that, we borrowed from rating agencies. And we said at the A- credit level and above, you're talking about the organizations that have the least amount of default on their bonds. In other words, they're the strongest from a balance sheet perspective. They're generally the higher performing organizations, better market positioned, and so on. And so we looked at this chart, and what we noticed was until 2013, those credit ratings of organizations that were the smaller entity in a transaction but still had an A- rating or above were only a handful each year, 2, 3, 1, and so on through 2013. But notice what's happened in the last 3 years. What you essentially have is nearly 35 organizations who have determined that while they have a very clear path to be an independent market leader, while they have a very clear way to support the needs of their obligations and debt and remain very viable, for strategic reasons, they've chosen that they needed to pursue a different path, a path that led to a broader or bigger partnership. And just some of the examples that are listed on the right are noteworthy. They include academic medical centers. They include religious-sponsored and Catholic organizations. They involve secular organizations. They involve organizations whose service areas are adjacent to one another or that they've filled in gaps around each other. But they also include organizations that have leapfrogged geographies altogether. Geisinger and Atlanticare, for example, where Geisinger left the state to pursue an opportunity in New Jersey. So there's a wide array of strategic rationales that are being undertaken as part of these large transactions, and they're certainly showing up in the level of activity that we're seeing. So in short, what this really means is 10, 12 years ago and before, most of what was driving transaction activity in the hospital space was some level of concern, some level of distress, most of the transactions had some element of defensive rationale as part of that. They were looking for capital, they were looking for financial support or capital support. But off to the right, it's very different. Transformative transactions today do focus on intellectual capital, cost efficiency for the long term, total cost of care are important considerations that health systems are considering. Scale and essentiality, and that scale and essentiality not just within the local market, but in a broader regional market as well. Diversification, physician platforms, and so on all summarize some of those same building blocks that we talked about in the business reconfiguration column of one of the previous slides that talked about pivoting to this new model, and that's what we're seeing by empirics in some of these transactions. That shift from financial and strategic rationale is also important because what it leads to is a focus on the greater good, the long-term synergies that are not just cost-related, but revenue-driven. Are there ways to pivot to a value-based reimbursement model that when you put the intellectual capital or the resources of the two organizations together, you can bring real change, not just to the quality of care, but also to the economics, to the bottom line of the organization. And what we're finding so far are the latch-on organizations of smaller community hospitals being added to the larger systems had much lower level of economic benefits historically than what we're seeing proposed and modeled in some of the much larger system transactions that we see today. And so the 1.3, if not properly executed, can often lead to 3.1, whereas the large systems that are coming together have very ambitious goals and monitoring procedures in place to assure that they can go from 2 plus 2 to equal 5 in some of their transactions. So it's more than just the number and the dollar volume of the transactions that are taking place. But when you look at a transformative transaction and you look at complements of health systems coming together, there's a very important driver that we've seen really accelerate over the last few years, and that is there's not necessarily a need for the organizations to fully integrate. And what that means is instead of having to be forced into a full-blown merger or instead of acquiring other health systems back and forth, there are a number of collaborative, less than fully integrated models that have started to increase in number and also increase in the size of the organizations that are transacting. And this helps illustrate that. Back in 2007, what we would call non-fully integrated structures, so non-mergers, non-acquisitions, things like joint ventures and such that we'll explain in a little bit more detail in just one second, were only 7% of the total number of transactions in 2007. So there were 61 total transactions in that year, of which 7% were these non-fully integrated, or what we call more creative, less than fully integrated structures. In 2014, the number of those types of transactions essentially tripled. And if you notice, it went from 61 transactions to 107 year to year. So not only did it triple, but it's a much higher amount because it's still that same proportion of the total number of transactions. Let's tear this down just a little bit further. Off to the left, you have a bar chart on this slide that explains that same number that we saw before of these non-fully integrated or less than fully integrated structures. And you can see from the bar chart that you have joint operating agreements that have increased in number, joint ventures that more than doubled in number, and also minority investments and management services agreements, which by and large weren't even represented or captured in 2007 because they weren't existing. And now here we are in 2014 where we have an array of new types of structures that are pretty significant. Even more telling is the column on the right. We took the same number of transactions here, and we actually allocated the revenue of the organizations involved. So the target, the smaller organization in these partnerships, what kind of revenue base were we talking about with these organizations? And again, back in 2007, we're looking at a little bit less than $1 billion in terms of organizations' revenue size in aggregate that were undertaking these types of transactions as a smaller entity in 2007. 2014, it's significantly higher. So not only do we have a higher participation in these types of structures, but we actually have much larger organizations participating in these type of structures as well. And that's because the strategic imperative allows them some degrees of freedom as to where and how to transact as they move forward. Another example of that is just seeing what some of these transactions look like. And we talked about a system-to-system merger that went cross-border in number 2. But number 3, with Northwell going to other verticals, starts to show that pattern of as health systems evolve in becoming central players in the inpatient care, they're now looking to see what else they can do in other verticals as well to provide that whole continuum of care. We also see data and technology coming to light with number 4. And then on the top with number 1, new health companies and ventures forming that are really network driven. Ascension and Trinity coming together to operate as a single network in Michigan. And perhaps very telling for the members of the AHA is the very top one, with DaVita and Independence starting an initiative called Tandem Health, where they're going to look to manage population bases, starting initially in the eastern Pennsylvania market. But notice there's not a health system as part of that organization in that equation there today. That's an aggregator of physician practices working directly with the health plan in ways to figure out where and how they can compete for managing population lives. And so as I mentioned before, there is the potential for new entrants to enter this market, and that's a fine example of one. Just one comment on process. Organizations that have in the past responded to or been part of RFP processes, typically that's how a transactional process will work. And so there's a memorandum that goes out, there's an RFP, you respond to the RFP and negotiate a letter of intent, and diligence and definitive agreements follow. Well, we find that's a little bit interesting, though, in some of these larger system-to-system mergers or the more collaborative style type partnerships, the process is very different. Organizations sit down and evaluate first, do they have a common vision or a point of view? They set their goals and objectives and also constraints, which is very important, what the deal breakers are. They determine the value proposition jointly. They look at one another and say, what are we actually trying to do here? How can we actually do it? What is the business case or the business rationale that could support what we're trying to do? And now let's go to the key terms and see if we can get the stakeholders to approve moving forward on this. And then we'll end in a similar place as the top line and schematic on transaction process with confirmatory diligence and definitive agreement. So our experience is the vast majority of the system-to-system partnerships that are coming together rarely emanate from an RFP process. They're actually direct conversations, executives and board members at times working together to say, well, what can we do together and how do we tackle the tough issues up front so we can get to a common place of success. So just a point on process there that we wanted to point out. In terms of outcomes, this is more of a takeaway slide. These are the general characteristics we see of successful partnerships. I think the second bullet on the right-hand column is one that we just discussed, which was the highly visible difference early on, and also communicating the successes. And in part, that really means making some of the tough decisions up front and getting through those gating issues right away so that the clear value proposition, which is the third bullet on the left-hand side, can really be demonstrated not just to the executives, but also at the board level. And just a bit of a war story here. We just find that when it's a really compelling story and we start to feel organizations really thinking about a collaborative and strategic partnership, we hear it first from the voices of fiduciaries. When the board members can explain what it is they see the advantage of that partnership at a level that they can share at a cocktail party or at the country club or just bumping into neighbors on their street, that's usually a pretty good sign that the value proposition is not only clearly understood and developed, but also brought to a level that community members can appreciate it and it can be communicated across those stakeholder groups. And so this just covers some of those general characteristics of those successful partnerships. So with that, we'll turn our attention to case studies and maybe build upon what makes some of the creative affiliations that we're seeing today creative. And perhaps a good place to start is a context slide and the array of potential partnership options that exist in a market. This slide on the bottom illustrates the pretty wide array of transaction structures that have come with industry transformation over the last few years. I'm speaking candidly here. About 12 years ago, about the only things that were taking place where every now and then you'd see an affiliation to the far left, and off to the right you'd see every now and then a change of corporate member if it was two not-for-profits combining, or if it was a for-profit acquiring a not-for-profit, it was usually an asset sale. And as I mentioned before, with those pie charts, with the joint operating agreements coming back in vogue and joint ventures now being pursued, management services agreements that are much more prevalent today, you can see a lot of boxes have really been added throughout this process and throughout this continuum. And in general, when you move from left to right, the level of integration gets higher, the level of control, if you will, by the large organization gets a little bit higher. And the local, smaller health systems' influence and control on what they're doing in the market generally gets lower as you move to the right. And those are those competing gray arrows that I go above and below the boxes. Beneath that are a number of deal component elements that we can skip for the purpose of this webinar, but they outline at least just some of the basic deal structures and tenets of transactions that are often observed in the various types. But what this really says is as you move to achieve more and more integration, as you look to get more and more support and commitment from a large organization, there is a trade-off for the level of control that is given up. And if we look back at the transactional related descriptors of what was happening over the last 10 years, that's why most transaction operated at the extremes about 10 years ago. Either it was a really light affiliation or it's moved all the way to the other end on the right-hand side where it was essentially an asset sale or a change of corporate member. Because strategy around industry transformation has changed, it's these middle structures now that are becoming more and more prevalent. And so for us, our perspective is form does follow function. When you look at these transaction structures and when you think about what to do in the middle or what to do that's not as common, typically it's because there are some very important goals and objectives or constraints that the parties have and that they have to custom fit an approach to a potential transaction. Let's illustrate these through some case studies. First one we'd like to talk about is Carondelet. This is an organization that was an Ascension ministry for quite some time. It operated in Arizona in the Tucson market. And just so we have the players right, Ascension essentially divested their 100% ownership right over that ministry. And we'll talk about the mechanics about it in just one second. But what emerged at the end was Tenet, the for-profit entity and hospital management company, becoming the majority partner in the organization. They would operate the whole business, and that the ongoing Catholic heritage and identity of the Carondelet mission would continue under that Tenet ownership. But they also added Dignity as another partner to this transaction. So Ascension essentially went from an 100% owner to a minority owner and ceded the ownership of the hospital to Tenet as a majority and then Dignity Health as another participant in that joint venture. And the quote really does say it all at the time, coming from the CEO of the health executive and what they were trying to pursue. But let's break this down a little bit more. The entity itself, $480 million in net revenue. So again, a very sizable organization itself. From the standpoint of where it sat within the market itself, though, it was a very competitive market. There were decreasing margins that were realized by all organizations in that space. The oversupply of beds was noted not only in the immediate service area, but also more broadly across the county. And so when you're in a market that's competitive, when you're in a market that has more capacity than it does have population, organizations that find themselves in the third or fourth market share position are probably fighting hard to figure out what network strategy they can undertake. And so in this market, what we had was a very large and very demonstrative market leader in the Tucson market, and then a number of other organizations that were figuring out where and how they could form a network to compete with it. And so Tenet and Dignity had already created an ACO, and it was the Arizona Care Network, that they had established previously. Again, Tenet, the for-profit entity, Dignity, the not-for-profit entity. And they had been operating in that network for some time and making some progress in figuring out where and how they can achieve a network that would get the attention of employers. And what they saw with an opportunity with Carondelet was to bring that organization into the joint venture as well. And what that does is, not only does it expand the network, improve sites of care, make you more attractive to employers and others that are looking for care, but it also limits the amount of capital expenditures the organizations probably have to undertake as well. If the three organizations remain completely independent outside of a network, there's a pretty good chance that the care capabilities and the requirements of transformation that we've talked about so far in the presentation all are individual investments, individual resources, individual intellectual capital these three organizations have to go get themselves. But combining forces in a network, they can reduce that amount of overall spend in terms of capital expenditures, and they can mitigate the need to get duplicative levels of intellectual capital and resources into their individual respective organizations. So that's what we have here. We have a joint venture that led to Ascension being the minority enterprise, Tenet and Dignity taking the majority of the joint venture relationship, with Tenet actually being the actual consolidating entity from an accounting standpoint, meaning that they had a 51% or higher interest in this overall joint venture. So what is the outcome of it? Carondelet was immediately brought into the Arizona Care Network through some discussions that Carondelet had and some conflicts that they had with their payers. There was a little bit of brinksmanship around whether or not that they would remain in the Blue Cross Blue Shield of Arizona plan. Eventually there was a settlement. Beyond that, Tenet extended its national contract with Aetna, and for the first time included not only Carondelet, but another facility in the Arizona market into that network. And so again, the concept of new collaboratives and new participants, a health plan that had a national contract with Tenet was brought in as an alternative to Blue Cross Blue Shield in this market to improve the level of competition in that organization, and also to allow this network to separately contract directly with employers. So this enables them essentially to become a healthcare company through the use of and the utilization of sites of care that extend all the way from a Catholic-sponsored entity to a former Catholic-sponsored entity, a non-for-profit entity, and a national healthcare insurer, all coming together as teammates in one market. And as you can see, Tenet anticipates these types of joint ventures continuing, and they claim that today 80% of their hospitals are going to participate in some form of these ACOs going forward. So clearly they're making a push in terms of where and how they aim to participate in the healthcare company realm going forward. Second case study we'd like to talk about is in Southern California. And I think it's fair to say, in comparing it to other metro market areas, probably one of the more fragmented markets. There's a significant amount of community hospitals, independent physician groups, and large systems that are still in that market that have not consolidated perhaps at the same pace and the same intensity of markets as Chicago, even to an extent Houston and New York. And so in this market, what you have is the come together of about 6 or 7 hospitals that were not focused on coming together in a governance way or in an integrated structure way, meaning they were not looking to merge, they were not looking to combine their organizations from the purposes of operational infrastructure or governance or other legal or corporate levels. Instead, they said, we all represent very important communities in our overall market, and there's not a significant amount of overlap across our 7. What could be done around a network strategy? And the conversations started to involve Anthem, who was a health insurer in that market, the Blue Cross affiliate in that market. And a joint venture was formed called Vivity, and it was aimed to go after large group employers and priced competitively against other HMO products in that market. And it also had a unique component of how to deal with physicians as well, to ensure that not only could you bridge a way through the fee-for-service reimbursement models we're seeing today, but also that you had a way to embrace the components of capitation and value-based that were coming. And so we constantly talk about this, you know, a foot on the pier and a foot in the canoe between fee-for-service, which has always been the case for reimbursement, to the canoe, which is starting to drift away around value-based reimbursement models. Well, this initiative aimed to address both of them. And so in this graphic, you can see how they did that. Essentially what they did was off to the far left, and again, these are what we called our customers in our new schematic of the new healthcare model earlier in the presentation. The customers here were public employers and large groups. So large groups of commercial patients that would look to Anthem and say, well, what if we became a member of Vivity? Well, the first thing is top left, probably top of mind for most of these employers. This network product was competitively priced at 10 to 20% current market premiums for other plans in the market. And speaking from press releases, Anthem cited Kaiser directly, their main competition, and said that's who we're focused on, and we think we could deliver a lower premium amount. Well, how did they do it? They formed a jointly capitalized, sort of the joint venture, which is essentially the nucleus of this chart, the Vivity entity there. And it contracted with a discounted fee-for-service basis on reimbursement for those 7 hospitals in that first ring. And so there was a discounted amount for fee-for-service, which led to a lower overall cost of care and allowed some of that premium dollar to be relieved a little bit from the employer's perspective. The second thing that it did is, as you extend further out, you notice the dark blue ring. That's the physician network that was underlying these hospitals. And that's where you have the professional cap right in the center of that arc. There was an arrangement that put into place value-based initiatives so that that physician network operated a little bit more on a value-based platform. And the overall reduction in that cost of care is what allowed them to fuel that 10 to 20% below market premium component. It also meant that you were telling your members that they're really committing to Vivity as being their provider of choice. And this is an interesting part. That commitment is one that we could see a very clear practical example of. And I literally stumbled upon this in researching Vivity, but this was publicly available by one of the organizations of Vivity. And what it does is, this is the summary of your healthcare coverage as a member of the Vivity HMO. And I draw your attention to the left-hand side in that light blue box. It says, if you have a patient surgery, and then keep going down from there, if you need immediate medical attention, and then also if you have a hospital stay. So these are the 3 areas of the network design that I thought were really important to point out here. So now go to the column where it says your cost if you use an in-network provider. So again, if you were committing to the Vivity model and you participated and got that care at one of these organizations here on this ring, then you are in this first category of your cost within an in-network provider. And you can see in outpatient surgery, assuming it was elective probably, there's no cost share. So your care is entirely paid for as part of that Vivity HMO model if you went to one of those 7 institutions. Now look off to the right. If you use an out-of-network provider, it's not even covered. And that fact pattern continues. If you go all the way to the bottom to the hospital stay, there's co-pays, and of course there's no cost share if you stay within network. But if you go outside of network, it's not even covered. Now emergency care, whether it be emergency medical transportation, urgent care, or emergency care, they're both covered in network, which is fine. And so that's Vivity's way of saying, look, if you have the ability to determine where you can get care delivered, it's a hospital stay, or if it's an elective outpatient procedure, we expect it to be a network. And we expect so much that you be a network that if you're not, you're essentially not going to be covered for that claim. So this is probably one of the more impressive network design components I've seen in some time that really show that the network is there, the savings are there, but the determination of how that care is selected by the healthcare care company is very clear. And the customers are limiting their choice as a result of getting that benefit. It's catching on. This slide indicates that in the first year, 35,000 members came over. Anthem was very happy to report that it believes it's drawing a majority of those members from its rival which was Kaiser. And in terms of potential growth, there was only 2,500 of the CalPERS workers that elected in this plan, but that's actually only 1% of the total member base. So if this starts to grow and emerge, you can see at least just with the initial organizations that they contracted with, just how significant this could be. So some concluding thoughts here. As we mentioned before, macro forces are changing this industry, and they're changing them not only in the competition that exists today, but in the overall basis of competition. And we started with this premise, but let us illustrate it again. It's no longer competing for which physician group to acquire or which hospital to acquire, which was the case 10, 15 years ago. Now it's figuring out what is that new competitive action that we can undertake with payers or with collaborators, organizations that once we competed with but now can be collaborators with us going forward. That's the new macro change and the outcome of it. The new base of competition requires a new value proposition as well. This movement to value causes us to think about how to be efficient in delivering care. And it also doesn't mean that you acquire everything in a market. It means that you look for what's best in a market, what organizations and health systems can do as their core business versus what they think they should go and partner with and utilize the resources and the intellectual capital of other organizations to come up with a better solution. So we talked about new partners for sure, and then also we're talking about bending the conformity of historical structures. What's most prevalent in the activity we're seeing around the organizations coming together in collaborative partnerships is that there is almost a premium in putting new thoughts and new structures into place, that there's not an adherence just to the traditional models that were used over the last 10 to 15 years. And what underlies that is that collaboration component. And so what we really suggest organizations take a careful look at is the keys to historical success in your rear view mirror about what were a good partnership and who good partners were may not be the same criteria. They may not be the same characteristics of the future partnerships as you look out your windshield into the future. That is what we see as the most significant change. And in fact, if we think about some of the key questions that should drive the further discussion of these topics, these are the four that we think really would help organizations crystallize in their head what are the components of this change in industry transformation that are most relevant to us from a partnership standpoint. Who or how would we think about a potential partnership, and what would we seek to get from that? And our point of view is very simple. Not everyone will have to partner in some way. Not everyone will have to collaborate or merge or enter into a joint venture. But we believe every organization is probably going to have an opportunity to do so, either one they initiate themselves or one that comes on their desk unprovoked and unannounced. And having the playbook to understand what the reaction to that for us is probably the most important thing that any organization could do right now. Thank you very much for your time.
Thank you. That does conclude today's conference. We thank you for your participation. You may disconnect your lines at this time, and have a great day.